Uh,
Good evening, everyone. To give our opening remarks, we have the current president of the Philippine Society for Gynecologic Endoscopy and the current vice president and incoming president of the Philippine Society of Climacteric Medicine. Let us all welcome Dr. Prudence Aquino Aquino.
Thank you, Gladys. Good evening, everybody. I am, as mentioned, I am Prudence V. Aquino Aquino, the president of the PSGE. Welcome to the 7th PSGE webinar and the 3rd of the series of PSGE Carl Storch webinar. I'd like to welcome back Carl Storch, Ms. Lawrence, Ms. Claire, and Mr. Henry. Our featured faculty, international faculty this evening, is no stranger to us all. We have met him because he has been part of our work congress for the past, for 2 congresses. He has been a faculty during our hysteroscopy workshop. The first one was in 2017 and the latest one was in 2019 last year, where he not only served as a faculty during the pre-congress GCSE program of the society, but also a surgeon during the telesurgery during the 15th annual Congress of PSGE called MIGS East Meets West and the first regional meeting of the SKA page in East Asia. I first met our faculty in November of 2016. I actually gate crashed into his hysteroscopy workshop, but this was with consent. So this workshop was during the 17th annual Congress of the A-Page in Taipei, Taiwan. So our history dates back to that time, and that is the start of the fruitful collaboration with PSGE. I would also like to welcome our second faculty. She is a PSG board member and an infertility specialist. And if we look at her Chinese roots, we can also consider her as an international faculty. Welcome po, Doctora. So before I proceed to the program, I would like to give my deepest gratitude to our very energetic and innovative Vice President and Head of Online Learning, Dr. Tonet Habana. She always manages to make our webinars one of a kind and worth waiting for even at 8 p.m. Manila time. Maraming salamat, friend. So next slide, please. I'd like to start off by welcoming the chair of the moderating team, Dr. Anne-Marie C. Trinidad. She is the treasurer of the Philippine Society for Gynecologic Endoscopy, the past president of the Philippine Society for the Study of the Trophoblastic Disease, active medical staff and member of the minimally invasive gynecologic surgery of St. Luke's Medical Center and UST Hospital. She's a professor of the Department of Obstetrics and Gynecology, UST Faculty of Medicine and Surgery. Friends, let's welcome Dr. Anne-Marie Trinidad.
Thank you, Dr. Prudence, for the kind introduction. Okay, so it's always an honor to be part of the PSGE activity, especially this webinar for tonight. Okay, so before we proceed any further, I'd like to, to orient our participants with regards to the webinar house rules. So participants other than the speakers are muted, and kindly send your questions via the Q&A or the chat box, and the questions will be addressed during the open forum. This webinar will also be recorded for future viewing. No? And we'd like to thank in advance all our participants for the cooperation. Now, at this point, I'd also like to introduce my co-chair for the night. She is a clinical associate professor of UP College of Medicine, Philippine General Hospital. She is also a board member of the Philippine Society for Gynecologic Endoscopy. She is the secretary and founding member of the Philippine Society for Fertility Preservation. She is likewise a board member for the Philippine Society of Climacteric Medicine, and she was the past president for the Philippine Society for Reproductive Medicine. Colleagues, I'd like to introduce my co-chair, Dr. Gladys Tanangonan. Dr. Tanangonan, you can have the virtual floor now to introduce our two respected speakers for the night.
Thank you, Dr. Anne. I have the pleasure of introducing our speakers for tonight. Our first speaker is a fellow of the Philippine Obstetrical and Gynecological Society, Philippine Society for Reproductive Medicine, and Philippine Society for Gynecologic Endoscopy. She is currently a member of the Board of Trustees of PSGE and the past president of PSRM and PSCM. She is currently the section head of the Reproductive Endocrinology and Infertility and Minimally Invasive Surgery section of Manila Doctors Hospital. She's also a member of ASRM, ESHRE, AAGL, ASPIRE, IMS, APMF, and World Endometriosis Society. Quite a busy lady. Our speaker for tonight is Dr. Joan Tan Garcia. The second speaker is Dr. Rudi Campo. I'm sure he's been introduced by Dr. Prudence, but let me introduce him more. So he is an internationally recognized hysteroscopic surgeon with a major experience in hysteroscopic uterine reconstructive surgery and hysteroscopic transendometrial myometrial exploration. He's the past president and chairman of the board of the European Society for Gynecological Endoscopy, founder and director of the European Academy of Gynecological Surgery, board member of the Leuven Institute of Fertility and Embryology, executive board member of the European Fertility Associates, and member of the European Society for Human Reproduction and Embryology. His current research interests are in the field of reproductive assistive technologies, endoscopic surgery, and training and education. So our second speaker would be Dr. Rudi Campo. So now to give our first lecture on the principles of hysteroscopic myomectomy, let me call on Dr. Joan Tan Garcia.
Can you see my slides?
Yes.
Okay. Thank you very much, Dr. Tanangonan, for your kind introduction. My role tonight is very simple. It's discussing the principles of hysteroscopic myomectomy. Definitely, I am not doing this for anything else but for PSGE, and it's from the information that I had gathered through my readings. Well, to start off, we know that this is COVID-19 pandemic times, and there has been so many things about the use of endoscopy surgery in these times now. PSGE in last April 22nd of this year, and again updated this July 6th, came up with 4 statements about hysteroscopic procedures. You can see it clearly on on the screen that as much as possible, we would like to do ambulatory hysteroscopy and outpatient daycare operative hysteroscopy with regional or local anesthesia or conscious sedation. Because the fear that we are transmitting with the virus, so that endoscopy was initially not allowed in most hospitals until recently, but with precautions. Now, if you look at the AEGL of 2020, July to August, this is the consensus statement that is released by AAGL regarding hysteroscopic procedures. As you can see, before you do such a procedure, you have to confirm the indication of the hysteroscopic procedure. And if you can defer it, if it's not an emergency, if it does not cause any significant adverse impact on the patient's clinical condition, we would prefer that you do it medically. So in cases where the effect of having that submucous myoma or the need for the surgery, then we do, the AAGL recommends that it be an in-office setting. And in the absence of office setting or office hysteroscopy, we will then proceed to the operating room with the precautions that are necessary. Plus, it should be done under local or regional anesthesia. So this is what the AAGL had released just recently this second half of the year. Now, what is the normal indication of operative hysteroscopy? We're talking about non-COVID times, no? Now, definitely it is for the removal of endometrial polyps, for uterine leiomyoma, specifically the submucous component, no? And the presence of uterine septa, removal of malposition of IUD, tubal recannulation, retained products of pregnancy is to be removed with the use of hysteroscopy, treatment of isthmoseals, direct biopsies, and intrauterine adhesions. Now, what we are doing actually is mainly for AUB in the setting of submucous myoma, recurrent pregnancy loss, and infertility. So presently, we all know that the current indications are namely excessive menstrual bleeding, pelvic pain or pressure, or whatever factor that is affecting reproductive outcomes for fertility preservation. With this, we have to know what are the conditions which will dictate the success of hysteroscopic myomectomy. Definitely, most authors or most people who are doing this procedure recommend the use of dilute vasopressin solution to be injected in the cervical area so that it will decrease intraoperative blood loss and distension fluid absorption significantly. The use of GnRH agonists is still controversial. There are some who are recommending it prior to the surgery or the procedure, and some are not very anxious about doing it. Now, we have to note there are the three different types of submucous myoma. You have your intracavitary, which we know as grade 0 or type 0. Then we have grade 1, which is less than 50% intramural, and grade 2, which is more than 50% intramural. So the degree of myometrial penetration is to be considered in cases when you would like to know if the procedure warrants immediate or what kind of procedure will be subjected for the patient. When we look at hysteroscopic myomectomy, proper counseling should be considered. Discussion with the patient regarding the surgical outcome, whether it should be a single-step procedure or it may be necessary to do a multiple step. Now, multiple step is usually when you are encountering multiple large, deep, or opposing leiomyoma, which necessitates several procedures so that it can achieve complete surgical resection, minimize intrauterine adhesions, formation, or both. First, that you have to consider whether it is suitable for hysteroscopic myomectomy would include on checking the myoma's relationship to the serosa. This is by way of ultrasound. How many submucous myomas are present in this patient? The location, size, type of submucous myoma should be an utmost importance when we consider whether the patient is suitable to have hysteroscopic myomectomy. How do we do the resection? Well, for one, we can use morcellation. 2, cutting with an electrosurgical loop. 3, the use of cold loop, which is what is now recommended, and vaporization, radiofrequency-based hysteroscopic myomectomy. So these are the 5 methods of resection. What is important for all those who are going to do the procedure, you have to note that care must be taken to ensure that the loop or whatever instrument you're using does not touch the adjacent endometrium. That way, you are reducing the possibility of post-op adhesions. The depth of thermal injury in tissue is proportional to the number of factors, including the voltage of the output and the exposure time. If the power is too low for the surface area of the electrode that is used, the electrode will now drag the tissue, thereby increasing the time of exposure and the depth of injury. Let's talk about how to prepare the patient. Well, definitely it should start with what is the type of submucous myoma the patient has. Is it type 0? Is it type 1? Is it type 2? Then, of course, let's not forget, what is the surgical experience of the surgeon? Is she well trained? Or she's just doing the step 1, step 2 procedure? Okay, she should also be adept with doing laparoscopy or laparotomy in case there is an emergency and complications like uterine perforation, bleeding because the lateral side of the myoma which hits the uterine vessels. So she should immediately be able to convert into a laparoscopy or a laparotomy to save the life of the patient. And let's look at the third one that is telling us patient preparation. The proper position should be achieved while doing and all the instruments at hand. Now, lastly, let us not forget that reliable instruments, camera system, light source are also likewise important. Pregnancy, according to ACOG Practice Bulletin number 6, should be excluded before you perform such a procedure. Of course, these women who have unpredictable menses can be scheduled at any time for the operative hysteroscopy. For higher risk of cervical stenosis or increased pain with surgical procedure, one should consider the routine use of cervical ripening. But in the absence of these conditions, there is no sufficient evidence that there is a need for cervical ripening. What are the preoperative cervical ripening agents? One is your intravaginal misoprostol, a dose of 400 micrograms at least 4 hours prior to the procedure. It reduces the need for dilatation. For postmenopausal women, however, let's not forget vaginal estrogen for 14 days before the procedure. In the ACOG Practice Bulletin, it claims that one should put 25 milligrams of vaginal estrogen. But here in our country, we only have 10 milligrams of estradiol vaginal tablet. So we are now using the 10 milligrams 14 days before the procedure. And according to ACOG, it goes along with 400 to 1,000 micrograms of vaginal misoprostol 12 hours before. Here in this country, because misoprostol, again, is not available, we are using evening primrose. Now, let's look at what are the other options. Well, one option is your laminaria. We all have that available. It is a vaginal osmotic dilator, which is inserted into the cervix to dilate the cervix. Of course, we should not also forget evening primrose, which had been studied and published, one of which is by our present PSGE President, Dr. Prudence Aquino, with the rest of the St. Luke's Medical Center, Quezon City staff, MIS staff, wherein they use Eve Prim or evening primrose intravaginally before hysteroscopy in women aged 37 to 77 years. Likewise, study done by Dr. Angela Aguilar, past president of PSGE, with Dr. Tanchoco. So this is what is available and what we are using. Well, another thing to consider is vasoconstricting agents such as vasopressin or epinephrine to be included in the local anesthesia to help cervical dilatation. Why is this necessary? The advantage of less cervical dilatation with instrumentation and thereby decreasing uterine perforation and cause of pain. When we talk about distending media, which is another important factor in the procedure, historically, it was more of COT and high viscosity fluid media like dextran. But this is only by history. Nowadays, we do use low viscosity distending media, namely normal saline and lactated ringers solution. What are the risk factors for fluid complication, which is quite often cited in most literature? Well, in the case of when you do a large or deep resection for type 1 or type 2, these things can happen because of long procedure, because the use of high pressure for a long period of time, and possibly because the cervix is not well prepared or there's severe angulation of the uterocervical junction, so that uterine perforation can be occurring in this patient. And such way the fluid complications come in. Or in cases with long procedure, more anesthesia is given and likewise causing such a complication. Now, let's look at what are the pointers to achieve minimal absorption of distending media. First of all, we have to remember you have to maintain intrauterine pressure of about 70 to 100 millimeter mercury. During the procedure, a very important member of the team is solely to calculate the fluid deficit, informing the surgeon and anesthetist at regular intervals. So he or she should be measuring the fluid deficit. For healthy patient, what is ideal is not to exceed 1,000 milliliter when using hypotonic solutions. And when you're using isotonic solution, it should not exceed 2,500 milliliter fluid deficit. So the goals of fluid management, which are prevention of excess absorption, early recognition of excess absorption, you have to choose the distancing media which is least likely to cause complication in the event of excess absorption, and you have to maintain a clear operative field at the lowest intrauterine pressure. Close monitoring of the fluid measurements all throughout surgery. What are the usual complications of fluid distension media, which will be very drastic for the patient? Because of fluid overload, because of hyponatremia and their consequence, the patient will now go into a state of having cerebral edema, brainstem herniation, and in rare cases, possibly death. What is now best used to correct this problem is the use of 5% mannitol with 274 milliosmoles by virtue of being isotonic and now lactated ringers being used as a fluid distension media. The question now comes in, if we're recommending pre-treatment with GnRH, how about what is the role of progestins or combined oral contraceptive pills? Definitely, if you thin out the endometrium prior to the operative hysteroscopy, there is an advantage to improve the visualization of the whole uterine cavity. So it is same for with pre-treatment with GnRH, thus reducing blood loss and improving visualization of the uterine cavity. This is specifically true for those women with severe anemia, because we want to buy time, not go ahead with the procedure, but prepare the patient in such a way that there is patient blood management, as we have been learning all this time from the time Dr. Delphine Tan has introduced the concept of patient blood management. Now, let me show you four techniques to do the resection. The first that I came into the web, I saw that there is the use of the myosure. Now, this first picture that I'm showing you is what we do conventionally. You can see the loop using thermal or electric energy. You are burning it up, and then at the same time using the cutting mode to cut it. So that's the conventional. This is the myosure. I'm sorry I do not have a video of it, but this is how the instrumentation with a very thin tip of a hysteroscope. You can shave, you can cut or shave it, and then at the same time, doing the resection, you can absorb the parts of the myoma. Okay. The other technique is the use of true scope, the true clear. Okay, true clear. So you can do multiple myomectomy. As you can see, this is the instrument for where true clear is being used. So the hysteroscopic or the resectoscope touches the myoma from the intrauterine cavity going towards the walls of the endometrium so that there will not be any damage. In this case, there are 3 myomas that are being done with this very thin, small diameter resectoscope. Okay, so you can see this. Now, the next one would be our intrauterine Bugatti shaper. Now, this one will be showing you that with this very thin, very small, minimal outer diameter, you're able to touch the myoma and with no thermal damage to tissue. Now, how do you remove it? It's just purely mechanical removal of the polyp, myoma, placental remnants. Direct suction of the resected tissue is possible. This is a safe alternative to most resectoscope. And the good news is it has optimized procedure time, enhanced safety, accessibility, and patient satisfaction. And I heard that soon we will be seeing this IBS machine or gadget to help us with our patient. The next one is your cold loop. Okay, this is what now we are recommending because with blunt dissection of the fibroconnective bridges which anchor the myoma. You can see, watch this video, and you can see there is no thermal energy. So you use the loop, okay? Just blunt dissection touching at the edges, at the sides where the pseudocapsule is supposed to be, thus making the intramural portion of the myoma becoming an intracavitary lesion, making it a one-step. So rather what is recommended in this COVID-19 pandemic, as you can see, okay? So that's called your cold loop resecting. Now, what are the other potential complications? What are the incidents and risk factors? Now, let us not forget the uterine perforation. The incidence is 0.12 to 1.61%. That is due to blind insertion of instruments. So without knowing the anatomy, you do not know that there is severe flexion, anteflexion, or severe retroflexion. So such anatomy would cause non-careful insertion of the scope causing the uterine perforation. Or in some cases, you have cervical stenosis or anatomic distortion caused by leiomyoma, congenital anomalies, intrauterine adhesions, myometrial thinning, uterine malposition, and a too deep resection of the uterine fibroid. When we talk about uterine perforation, For you to suspect that it had happened to your patient which underwent hysteroscopic myomectomy, the patient will have post-op fever, complaining of abdominal pain, nausea, or vomiting. When you do the laparoscopy to check or laparotomy, you have to check the areas where the perforation has happened so that you can check the adjacent injury, whether it's the bladder, it's part of the intestine, during your procedure. Now, what causes this? The reason is due to the thin free myometrial margin. So thus, prevention of this to happen, what is recommended is the use of intraoperative ultrasound. You have an abdominal ultrasound simultaneous while you are doing this procedure, or you use the cold loop instead of the electric loop. So what is important is your pre-op assessment using the 3D ultrasound. It will be a great tool to aid you to avoid uterine perforation because you would know already how much is the distance of your dissection to the serosal surface. So what is important is that you need to be highly skilled or better trained endoscopists to do this procedure. The next thing we have to remember is the fluid overload. So the incidence is 0.20%. And this is largely due to excessive absorption of any distending media when you're doing a resection of a large or deep lesion. There is the use of high intrauterine pressure for a long time, so such that there is increased risk of hyponatremia with the use of electrolyte-free distending medium. What would happen? There will be cerebral edema with hypotonic distending medium. Hemorrhage is another problem. The incidence is not so high. It's 0.03 to 0.61. It's due to cervical laceration, uterine perforation, when you're doing adhesiolysis without coagulation, and resection of cavitary lesions. Bleeding can be prevented. For those who are anemic, we are recommending, or the authors of previous papers recommend the use of GnRH analog or SPRM and iron supplement. At the moment, we do not recommend SPRM because let's not forget it has been recalled because of the liver failure or toxicity. Now, let's remember also the present recommendation of the principle of patient's blood management, wherein pre-op anemia is a risk factor for intra-op and post-op complications, such that pre-op GnRH for 3 months would build up the patient's hemoglobin. This is recommended drug during this time of pandemic, wherein the first choice for patient's management is to build up the patient's own iron stores or the hemoglobin before you embark to do a major surgery like a hysteroscopic. What is the remedy for bleeding as a complication? Well, one of them is the recommendation of the use of uterotonics in the form of oxytocin, about 5 to 10 units IV. And according to Emmanuel, vasopressin injection with the use of dilute vasopressin solution of 0.05 to 1 unit per ml, or the use of misoprostol. The other way is to do an intracavitary balloon tamponade with Foley catheter filled up with 30 to 50 ml fluid. Of course, let's not forget, if you are considering uterine perforation as a source of bleeding, laparoscopic or laparotomy suturing is necessary. Type 2 fibroids of more than 6 cm constitute limits of this endoscopic technique unless you are very surgically well equipped to do such cases. Incomplete resection, what is there to be said? Well, definitely when you have an encountered incomplete removal, it signifies a well understood precaution, thus reducing complication. So if you see that you have achieved more than the maximum limit of fluid deficit, you have to stop, okay? You have to know that what is in store for the patient is safety. So you have to reschedule the patient to lower the overall risk of complication. Infection, on the other hand, is very low in most reports. It is only increased with manipulation of the cervix during dilatation. Vagal reaction, which is mentioned by A.I. Dennis and his colleagues. This is due to triggering of parasympathetic nervous system during manipulation of the cervix and instrumentation of the cervical or uterine cavity. As you can see, the incidence is variable from 0.21 to 1.85. Air and gas embolism. Let us not forget that repetitive instrumentation through the cervix can cause this. Inadequate purging of air from the tubing and instruments, and excessive intrauterine pressure for a long period. What would the patient be having symptoms of? Dyspnea, chest pain, churning, or splashing murmur. Venous intravasation or operative hysteroscopic intravascular absorption syndrome, or better abbreviated as OHIA, is a very rare complication. When large volumes are absorbed into the circulatory system and the myometrial vessels are open, causing fluid overload, electrolyte imbalance, and serious complications like pulmonary edema or cardiac failure can occur. How do you prevent this to happen? Scrupulous fluid balance. So somebody has to be monitoring closely what goes in and what goes out. Now, the signs and symptoms of patients having this problem would be headache, drowsiness, in severe cases, convulsion, apnea, vomiting. Okay, so that is what's going on: electrolyte imbalance, pulmonary edema, and worst scenario is cardiac failure. What is the important pointer? Again, I would like to reiterate, you have to limit the isotonic media to not more than 2,500 milliliter, that is deficit, for isotonic. For hypotonic, it should not be more than 1,000 ml. For high-risk women who have cardiac problem, especially we're talking about postmenopausal or perimenopause, the maximum amount of absorbed fluid for isotonic is documented to should not be beyond 1,500 ml, and for the use of hypotonic media should not be beyond 750 ml. So the treatment for minor OHIA is the use of furosemide. One of the complications we have to also consider is the occurrence of venous air embolism. Now, it occurs from medium use to expand the uterus during electrocoagulation and directly from the air in the OR. The symptoms are chest pain, breathing disturbances, shortness of breath, cough. Now, this can lead to arrhythmia, pulmonary hypertension, gas exchange disorder, and in very rare cases, death. Bipolar, it is to be remembered, bipolar systems do produce more air bubbles. So it will cause an increased risk for venous air embolism. However, with the bipolar system, there will be a less likely to cause OHIA. So you have less chance of OHIA but more higher for venous air embolism. So how do you manage these patients who you are suspecting to have venous air embolism? Terminate the procedure immediately. Locate the gas inlay and remove the hysteroscope immediately. Give 100% oxygen. Close the cervical canal instrumentally and place the patient in Tredelenburg position on the left side, what we call now Durant maneuver. And of course, ask your friendly anesthetist to give genotropic positive agents. And in some extreme cases, the patient may have to undergo cardiocentesis. Prevention is the key issue when complications are concerned. Train the staff, the nurse who are helping you, the residents, or whoever is assisting you during the surgery regarding complication. Design a local procedure plan. Proper monitoring all throughout the procedure is necessary, and the correct position, slightly inverted Tredelenburg position. I post this because some patients would have poor healing after the myomectomy. Now, this is because the neurotransmitters and neurofibers in the myoma pseudocapsule have to be preserved, since more fibrosis will result to hypoxia, ischemia, and necrosis at the area left. avoid high voltage diathermocoagulation or excessive tissue manipulation or muscular trauma would therefore improve physiological myometrial healing. Thus, avoid myometrial complications during pregnancy, labor, and delivery. I just would like to share you that AAGL has several practice guidelines. I would suggest, because of the lack of time for this webinar to go through, to go to the AAGL recommendation that was published in the journal between March and April of 2012. So there are level A recommendation, and then there's level B recommendation, and level C recommendation. So to close this, I would like to conclude my lecture by sharing that pre-operative evaluation is important in decision making so that ultrasound technology and computer are needed. The extension to the intramural portion and remaining myometrium depth behind the myoma is of utmost importance. Hysteroscopic morcellation should be learned and mastered. For heavy bleeding in AUB preoperative preparation with, I would say, pills or progestin are advantageous. Of course, GnRH would be much better. Decision to stop procedure and do the second step would lessen the incidence of fluid overload, venous air embolism, and other complications. Know when to stop, okay? And then the mastery of the whole procedure is essential for the success of the whole procedure. I think I would like to express gratitude to Dr. Habana for making me study and learn this all together tonight and sharing it with you. Thank you very much for your attention.
Okay. Thank you, Dr. Joan Tan Garcia, for that comprehensive lecture on hysteroscopic myomectomy. Okay, so we'd like to encourage our participants to please post your questions in the Q&A or in the chat box. Okay, so after hearing the principles of hysteroscopic myomectomy, as mentioned by Dr. Joan Tan Garcia, in these times of pandemic, it would be better to do outpatient hysteroscopy, and we're very fortunate this evening to hear it from the expert himself. No? So who will be talking on outpatient hysteroscopy, the Life Expert Center, methodology, COVID-19 proof, no other than from Professor Rudi Campo. Professor, may we have your lecture?
I unmute. So welcome everybody. I'm very happy to be with you. I'm very sad not to be in the Philippines. Always extremely nice to be there, especially the karaoke. But in those times of COVID, we need to invent and to explore new methods of sharing our knowledge. And I think this kind of webinars is fantastic. So I'm very happy that I can share with you our new concept, outpatient hysteroscopy, the Life Expert Center methodology. The Life Expert Center has actually reorganized its care system in function of this COVID-19 threat, following governmental regulation and using progressively new insights provided by scientific publications. And we have quite dramatically reorganized our ambulatory care. This is on the level of center organization, equipment, and clinical approach. So this is the Life Expert Center in Leuven, Belgium. Beautiful building, but not everything is Life Expert Center. Would be nice. It's the Life Expert Center is a part of the ground floor there. Very nice entrance, very nice secretary. People are attended. We try to do precision, individualized medicine, friendly appearance, and we have a full equipped ambulatory OR where you already see one of the important things is that we have a screen of ultrasound and a screen of hysteroscopy. So ultrasound and hysteroscopy for us goes hand in hand. It means that in the majority of cases, we really do not need laparoscopy or other imaging technologies.
is when you touch your own mouth, nose, or eyes.
So the virus is spread in large droplets by coughing and sneezing. And I don't know if the video worked, but if you see the lady,
is when you touch your own mouth,
so
nose, or eyes.
to adapt to what we say. Air will not infect us, but all the surfaces where those droplets land are infectious for about a week on average. This is James Robb, famous guy from San Diego. The virus only has cell receptor for lung cells. So this is basically the concept when you reorganize us, where you have to take care. We will not change ourselves in this way. We try to find a way to keep our patient-friendly approach. And for this to have this goal, only admission patients for technical acts. The partner cannot come. There's a specific sanitation program, high-risk procedures like ultrasound, follow-up, ovarian stimulation, small rooms, a lot of caseloads. We have a specific organization for that. And so this means that we need to find a way to discuss correctly with our patients and to inform them on what we've done or what we are going to do. And if you are in a COVID environment, you have your disinfection, everybody with the mask. We hate the mask, we don't see the faces. It's very difficult to have a good contact with your patient. Whereas if we start with the Zoom as we are doing now, we see the patient at their proper environment, no mask, very nice communication. It's a new era. We can put all our imaging technology or the results on the screen, pinpoint. So for example, in this case, there's a Robert's uterus. So we explain the patient, we will go inside with ultrasound guided procedure. We will make the connection with the rudimentary horn not communicating, and we will make a normal cavity. So we can show videos. So it's really, if the patient satisfaction rate is enormous, they don't have to travel. We have a lot of long distance patients. So this is really, thanks to COVID, an improvement. We have the questionnaire of X-ray before patients comes into the facility. We do PCR and antibody tests prior to treatments, and we have regular testing of the personnel. But we have to be careful with testing. If you see this also very interesting publication, you have a lot of false negative results. So prevention with questionnaire and careful protection of individuals when there's close contacts, depending on the incidence of the infection rate, is probably the most important, because even on the day of symptom onsets, we have 38% of false negative, 20% on day 3, and if you do prevention on day -4, 100% is false negative. So really, also the result, the PCR is not 100%. So limit the number of persons simultaneously present in the center, PPE sanitation, redesign of waiting rooms, and subdivision of staff. We have one staff is only dealing with the Zoom consultations and is sitting home, and we have another staff which is permanently at the facility. When somebody gets sick, then we can change the staff. The permanent staff, if there is an infection, they go in quarantine, no problem. They do quarantine at home and can do the Zoom consultations. So our beautiful waiting room is now, they come in, disinfection, mask, people sit here, and then they have to go directly to the examination room. We always do temperature management when they enter. And then, so people, entry door, exit door is there. So absolutely everything in administration is done prior to the admission to the clinic. And then they go in the treatment rooms. We have 4 treatment rooms, and from the treatment room, they go into the examination room. This was prior to COVID. Today, there's only a nurse, the patient, and a nice illumination. This is a video we made
Hello,
for
everybody.
the Miss Academy.
A new project is born.
Miss Academy Leuven and Dubai bring you surgical competence in your office. I'm standing here in the Life Expert Center, a totally new project, and we will be able, if you become a member of the Miss Academy, to provide you with the whole surgical gamma of hysteroscopic, ultrasound, minimal invasive uterine diagnosis and therapy. How are your skills in hysteroscopic surgery and moreover in ambulatory hysteroscopic surgery? Well, Miss Academy, with its web-based surgical competence platform, will offer you the possibility of real proctorship. I will bring you my Life Expert Center ambulatory OR to your home. We can discuss, we can dialogue, and you can progressively increase your competence in hysteroscopy. As you see, we work with 3D ultrasound and high-tech camera systems, and we have our patients coming in and out in a very efficient modality. So, to do this, you need high-tech equipment, obviously. So, the trophy scope or the Campo trophy scope is really the access to the ambulatory environment. With our Lancet published study, we showed that in infertile patients, we had not one access failure in this prospective randomized controlled trial. And so we entered the cavity with this very small 2.9 millimeter in total diameter single flow instrument. When we need a Doppel flow, we can forward the outer sheet. So there's a freedom of space here of 7 centimeter. And depending if we have a diagnostic or an operative sheet, we dilate the cervix to 3.7 and 4.4. So no speculum, no tenaculum, nothing. The only thing we use is the vaginal probe for ultrasound, which is our first exam, then the hysteroscope, and then at the end of the diagnostic procedure, we repeat the vaginal ultrasound because we have contrast. The second instrument, which has already been mentioned by the previous speaker, is the Bugatti shaver. But also with the Bugatti shaver, we got the easy pump entering. The easy pump, which measures the intrauterine pressure. Extremely nice for the patient without sedation, because you can really adapt the intrauterine pressure to the necessities at the lowest possible pressure to visualize the cavity. And then you see this is the normal shaver optic, but this is the mini shaver optic, which is absolutely atraumatic and which is 100% compatible and interchangeable with the Trophy XL and with the mini bipolar resectoscope. So the little thieves, so the shaver is the instrument for soft tissue removal. And I would not call it morcellation. It's soft tissue or mechanical tissue removal, in which also the COVID recommendations have stated that trophy shaver is actually, or the mechanical approach is the approach which we should choose if possible. So if you have soft tissue, also Bugatti showed that to learn and to work with a shaver is less dangerous than any other surgical instrument, because the job is done by the shaver, not by the surgeon. As you see here, a very large polyp, several polyps. If the tissue is soft, size does not matter anymore. We know for myoma resections, large myoma are really dangerous for hysteroscopy, take a lot of time. But when you can remove them with a shaver system, then it is absolutely feasible to go in sizes above 3-4 centimeter. In our facility, as I've shown you, patients has to leave the facility within 1 hour after surgery, walking outside. And then the husband gets, or the partner will get her. And then fantastic instrument is the mini bipolar. Here's the isolation, mini bipolar resectoscope, which offers us a very precise cutting capacity The bubbles are still there, absolutely, but with a good flow system, we can remove the bubbles correctly. And the ships are small so that they go out spontaneously, which is a huge difference. So the technique of surgery is also a little bit different to make ships as such that they can go out spontaneously. And then we have our instrument set up, which the smallest is the trophy, 2.9 millimeter. We can dilate till 4.4. We can go from one instrument to another. We always have all instruments at our disposal because all instruments are disinfected with high-level disinfection, which is called Tristal Fuse. It's chlor dioxide and extremely efficient against all germs. Even studies show that it should work against prions. So what the clinical approach, let's take two challenging situations. First of all, the diagnosis. So we have the ultrasound, hysteroscopy, contrast sonography. This is the way to go forward. In ultrasound, you see that there is something. The hysteroscopy shows exactly that it's a type 0 polyp myoma. And here in contrast, you can measure clearly, you see the surrounding myometrium. Here, difficult ultrasound because we are not experts in ultrasound. That's clear. We see endometrium. Is this a myoma? The 3D helps a lot. Here you see a myoma from the lateral wall. And then you have the hysteroscopy, which confirms, and the contrast sonography, which helps a lot. For the cavity deformations, for example, in 2D, you have a small cavity here. Then you say it's an atrophic endometrium. Hysteroscopy shows that this is an abnormal cavity, a dysmorphic cavity, according to the new classification. And with contrast, it is confirmed. And then the 3D ultrasound, extremely important to have all those different small changes of the cavity with or without an indulation or just a small cavity. But all of this is class U1A, B, or C, according to the new ESG S-Ray classification on congenital malformations. And if you see the infertile patient, because the abnormal uterine bleeding patient, it's polyp myoma, but the infertile patient is really interesting. You have congenital malformations and predominantly the small ones. You have adhesions, necrotic tissue, not a lot of myomas, and polyp changes. And when you see the subtle lesions, there we do not have this large quantity of mucosal elevations, but the strawberry, so reddish, irritated endometrium, polyposis, necrotic tissue, and synechia. So a really infertile patient is a very challenging and interesting collective. And there the question is, if we do some research, we need a correct definition of normality. So in 3D ultrasound, we have a triangular cavity. In hysteroscopy, we can see the tubal ostia by turning our 30-degree optic. This is an example with a wide angle optic, but this is what you should have. And in magnetic resonance imaging, which we do in research for research purposes in infertile patients with failed implantation or prior to egg donation, we see that the muscle, the myometrium, is divided in two functional entities: the outer myometrium, where the cells are responsible for the delivery, and the inner myometrium, which is the implantation, a much more complex function. And then the question is, when I have a deformation of the cavity, of this polyposis, subtle lesions, or a total loss of junctional zone differentiation, what does this mean for the individual? What does this mean for the patient? And what do we have to do? So an example here, you have a dysmorphic cavity. This is confirmed in ultrasound with a little cyst there, but a normal junctional zone, so no sign of further adenomyosis. And here is the cyst. There is the tubal ostium, so we have the landmarks, and we see that the cavity is deformed, and this is a patient with failed implantation. So beautiful embryos, no pregnancy, and we start to do the surgery on the fundal part, so to align the tubal ostia. And what do we find? We find all those little bloody cysts, and which is really striking, and which really surprised me, is that those cysts were not seen in ultrasound clearly and not seen in magnetic resonance imaging. But with the hysteroscopic exploration of your subendometrial myometrium, we could demonstrate that the whole septated, or the whole fundal area, here you see a big cyst coming, was invaded by adenomyotic cysts. And this is, from a diagnostic point of view, very important, because this means that patient will be treated with GnRH analogs prior to embryo transfer, and that in such a way, by reconstruction of the cavity, removing of the cysts, and GnRH analog treatment, implantation can be improved. Now, if we want a histological diagnosis, then it is very difficult with the simple hysteroscopic instruments to make a whole wall biopsy. We do not want to do true cut, because true cut is really a cell spreading. So what we do is we have the spirotome, according to Stephen Gotts. It's a cutting helix, which is put under ultrasound vision or under hysteroscopic vision, but mostly under ultrasound vision. You go up to the serosa, then you have a cutting cannula, and then you have a nice biopsy all the way through endometrium, myometrium, junctional zone, and outer myometrium. And all of this is done through the outer sheet of the diagnostic trophy scope. So you don't need speculum, you don't need any fancy activity to insert the spirotome, and you do it on the abdominal ultrasound control. And nothing much is published on the importance of the junctional zone differentiation and reproduction. So we have a prospective observational study in an egg donation program in women above 40. All those women receive ultrasound, hysteroscopy, and magnetic resonance imaging, and all those women receive the protocol by one physician. In 114 women entered in the study, 38, only 38, 33% had a normal ultrasound and a normal hysteroscopy, according to the criteria previously mentioned. The overall take-home baby rate after one donation is 65%. Now, when ultrasound and hysteroscopy is perfectly normal, we see that there is a take-home baby rate of 74.2%, which is better, obviously. And when the MRI is normal, I'm sorry, so hysteroscopy and MRI is normal, 74.2%. Now, when hysteroscopy, ultrasound is normal, but MRI has a problem, like demonstrated here. Until today, we do not have one delivery, only failed implantation or miscarriage. So no proof, but certainly very interesting data, in which we have to go further than the surface. We have to see what is behind the curtain if we find subtle lesions. And a second very interesting and controversial theme is the subtle cavity deformation. We have the triangular cavity, and then, as I showed you before, all those different forms of dysmorphic uteri. If we do ultrasound, we see this very small cylindric hole. We turn our 30-degree optic, and what do we see? This is not the ostium, this is a membranous ring before the ostium. The ostium is behind. We do a 3D ultrasound, we see an indulation, and we see a dysmorphic uterus. If you do this with a 5 millimeter instrument, everything is ruined. You can only do this with a very small instrument, otherwise you start to damage the endometrium. If you want to do here or here a surgery, your result should be this. You have to bring a line from the tubal ostia to the ostium internum cervicae. The same here, and you make a straight line in the fundal area so that you get this nice triangular form. We do it with the scissors. As already mentioned, we use as less as possible laser or electrical energy, only when it's necessary. This comes from the time where we were microsurgeons, pinpoint coagulation, and then anatomical dedicated dissection. And we make this straight line. We put our easy pump under the arterial pressure, so when you have an arterial bleeding, you will see it immediately. And the little capillary bleedings, we do not coagulate. So you have the tubal ostium, we go downwards, you see those little bleedings, absolutely no problem. We made a little incision in the fundus and we have your tubal ostium with a straight line downwards. Once this is done, we put the gel. In our earlier days, we had some adhesion formation or inappropriate results after surgery. And since then, we routinely, in every case or in every infertile patient, we do an application of the hyaluronidase gel with very good stiffness so that it stays in the cavity and can be used also for ultrasound purposes. It's very good contrast. The gel is applicated through the sheet of the trophy. So you see first a little bit of blood, you have here the trophy scope, you have the contrast, and you have, first of all, the gel remains, the matte region gel remains 2 weeks. So it's very interesting. There is no animal products in the gel, so it's very well tolerated. We never had one adverse effect with it. And it even could have an influence on the endometrial function. Now, it's very difficult to do a study on this, but it was in 2017 for the first time reported at the ESHRE Congress in Geneva. And anyway, if we do studies, we have to implement this possible beneficial effect of the gel on the reproductive performance. Now, how many studies have been published? The first publications came in 2019. Jaime Ferro from IVI Valencia, one of the best fertility institutes of the world, published his data, and they are extremely impressive. Although it's a retrospective observational study, it is one surgeon who did all the cases. There is no bias, and this is very important because in hysteroscopy we work with images. If you compare two surgeons, you do not have an agreement. So if you do a study, it should be one surgeon and not 28 surgeons like the TRUST study. One surgeon, all indications verified by the same surgeon, all the controls by the same surgeon. And if you see what the results of Jaime Ferro are, 80% clinical pregnancy rate in 190 women with repeated implantation failure in IVI Valencia, an absolute #1 IVF institution. Even people from Valencia said you do not need the womb, you only need a good embryo. It's not true. In those cases here, you see a very live birth rate of 77.9 and only 8.9% abortion rate, which is incredibly good. And at 12 months, the clinical pregnancy rate was 76%, at 6 months, 50%. And within the first cycle, they had a live birth rate of 77 and 86%. Pregnancy rate of 77 and live birth rate 86. And the mean time also very short, 6.5. And since then, you have a lot of publications. I put them all on one slide. Ours, Attilio and myself, we have the largest number of all, 214. Identical results like Ferro. And also here in our center, I'm the only one who operates in Naples, only Sardo. So we have no inter-observer variation. The other studies have biases, you can have discussions on them, but they all have the same results. So very interesting. We should take care of those small changes of the uterine cavity in infertile patients. Now, if I still have the time, I would like to share with you two difficult challenges: Asherman and treatment, hysteroscopic approach to adenomyosis. Today, we work with the face shield, one nurse, one anesthesiologist, and we do all our interventions under conscious sedation. Patients leave the facility 1 hour after the surgery. So the first, I will give you some tips and tricks on treatment of Asherman. So here we have the 3D ultrasound, and you could think it's an easy case. We start here to cut into the adhesive tissue, and what you directly identify is that it is very hard. Now, very hard tissue, then you have to change your strategy. We have to go to a bulk resection as much as possible. We have to try to remove this in one block and try to find the entrance under ultrasound guidance, abdominal, and we follow here the right lateral wall and find this little hole. Now, this could be a tubal ostia. If you perforate this, then you're in the abdomen. But ultrasound shows you that the beneficial effect of ultrasound, that we still have a security margin, and that behind a cavity is filling with fluid. So with the trophy, we first go with the optic, then we dilate visually, and we see the tubal ostia. So block resection is one technique. Once we have done this, once we have found the access, we have to remove. If you leave this kind of tissue, it will adhere. You can do whatever you want. It will adhere, and you have done nothing. I've seen patients who have been operated correctly 7 times, but they forgot to remove the cicatricial tissue. So here you see an example, because it's a large area of very hard tissue. This does not work with the scissors, but with this mini bipolar resectoscope, there is a very nice cutting capacity, and you see very nice the differentiation with the surroundings. We can gently push, and you see, nice. No carbonization, no terminal injury, excellent instrument. And the job is to remove here. And then the question is, certainly, and that we will address later on, what do we do more to prevent re-adhesion formation? Another challenging issue is when one half is open and the other half is totally closed. If you come with the scissors, it's impossible. You have to come from this direction to find here the hole. With the scissors, you have to start here and then be lucky that you can enter in this very little, in ultrasound, nearly visible endometrial halo, which is the cornua. So how do we do it? We use the spiratome. We go inside with the trophy, remove the optic, and replace by the spiratome. And with an expert ultrasound help, because this you cannot do yourself, you need an expert sonographist who says up, down, and we go with the corkscrew in the little endometrial halo. Once it's confirmed that we're on the right spot, and the corkscrew, you can turn back, you turn in, there's no damage. Then we put the outer sheet, and you see here, no bleeding. It is an atraumatic tool which is used, it embraces the tissue, and it is used in all sorts of biopsy in cancer, in oncological situations. But it's extremely nice here also to help us to find the access to the cornua, because for surgery, you need your anatomical landmarks. You need your ostium on the right, you need your ostium on the left, and then you can finalize and do the job. Another very nice technique, which was firstly described by Sarah Velos, who was at that time in Hong Kong, now in London, with T.C. Lee, who was in Hong Kong, is when you have a cavity, but everything is adherent, you can put a 8 or 10 French silicone balloon, ultrasound probe and you do inflation, deflation, inflation, and you see that there is sufficient myometrial environment, but this was a cavity, the same case as before, where you only had one ostium visible and the other side totally obliterated. Now, after this dilatation, obviously, the cavity is really damaged. And we see that the cornua on the right side still has adhesion formation, but a nice cavity after cleaning up and access to the tubal ostium is found. And again here, once we have the two cornua and identification of the ostia, we can resect. And with the balloon technology, we only resect the firm adhesions and we do not touch the endometrial adhesions, which are all opened, that's its little cornua, all opened by the pressure of the balloon. Oh, and then last but not least, this is the balloon of Ward. If we have huge damage inside, we put this little balloon inside, which is 5.5 centimeter, before we put a gel, but then we just take a Pozzi and we push this inside, so this will not come outside the cervix. So this is at the little bit further than the internal os, and you see the balloon here, which remains for 2 months, and then we remove it, or it is expelled by the contractions of the womb. Very, very good system. So the gel has scientific evidence. I think it is really general acceptance that, and also if we see the AGL ESG 2017 joint publication on intrauterine adhesions, the application of an adhesion barrier following surgery that may lead to endometrial damage significantly reduce the development of adhesion formation. So it's a level A recommendation, so our strategy is always gel and eventually the balloon of Ward supplementary. And this is the result of a full Asherman, and supplementary patient became pregnant and has a baby. Placentation can be difficult, manual removal or even serious situation with the placenta and up to hysterectomy can happen. So we have to be careful on that. And then adenomyosis, really the new game of hysteroscopic surgeons. We have the junctional zone, we have the disturbed junctional zone, we have some typical subtle lesions like the defects, or lesions in ultrasound like the hyperechogenic zones, which we have to examine. So in this case here, you have only enlarged anterior wall in ultrasound and normal posterior wall. You have in magnetic resonance imaging a focal change in cell imaging, or in myometrium imaging. So you have here a possible focal adenomyotic lesion. In hysteroscopy, everything is normal. Now, based on what we see here, we do an hysteroscopic exploration of the subendometrial myometrium. And the hysteroscope sees clearly that there is a fibrotic area, there is a pseudo wall, and the scissor with the blunt tips is actually not so difficult to dissect, resect, and remove this fibrotic tissue, which then can be confirmed by the pathologist being an adenomyoma. When it starts bleeding, only then we do pinpoint coagulation. So again, mechanical surgery. Another example of an adenomyoma, so we have an incision of the side wall, this strange structure is totally irregular when we try to dissect it, but you see here very neovascularization. And you see here the capsula is vascularized. It's a pseudocapsula in the lateral wall. So somehow larger adenomyoma, which was dissected by mechanical trophy hysteroscopy. What do you think we have here? Tubal ostia, protrusion of the wall. And if we lower the pressure, it looks like a type 3 myoma. Now, the only way to know this is to explore. So we take the mini bipolar resectoscope, make one cut, and what do we see? Well, we see the myometrium, a muscle, no capsula, nothing. We go further. And what do we see? Belgian chocolate. Chocolate dye is coming out and we clean with the resectoscope the Doppler flow and have the appearance which is identical to an ovarian endometrioma. There is no difference. It's an invagination with superficial endometrial implants and neovascularization. So what do we do now? We will not destroy the whole uterus. Oh, sorry. We will not destroy the whole uterus. And this is in our hands. We do it with the mini resectoscope because very nicely we can remove the endometrial tissue, find the pseudo cleavage plane of the capsula and resect all particles. At the end of the resection, so you see the particles, at the end of the resection you have an equal image, but if you go and look a little bit closer, then you see that this is the correct level of dissection. Now you need ultrasound, obviously. So we dissected up till here and removed the cyst. And then we measure, we have always our 0.5, between 0.5 and 1 centimeter security zone. Adenomyosis is a disease of the muscle, so you can perforate. If you are working inside the muscle, and if you remove something, it's diseased muscle tissue you remove. And then this is an image of Bigatti, who is now in Renji Hospital in Shanghai, and who has opened in August the first Sino Life Expert Center. And look, he was doing a polyp. It says, oh, look me, this is adenomyosis. So the polyp was the sign of adenomyosis. And with the shaver, I've never done it, but you know, Bigatti is in love with his shaver. With the shaver, he is trying, or he is removing the adenomyotic tissue. You see, here, very typically, this little opening. There it is. And step by step, he removes nearly the whole adenomyotic cyst, which was underneath the polyp. So, dear friends, the Life Expert Center Clinic is a new concept of precision medicine. It offers the possibility, well-organized patient comes and we do everything because we are predominantly treating infertile patients, and everything is done in one visit, prepared by telemedicine, consultation afterwards by telemedicine. The one-stop clinic and the telehealth organization offers a cost-efficient structure with the possibility to provide services to a large demographic area and also under strict COVID regulations. We have fallback for every situation. And then, as I already mentioned, so we opened now in August, just recently. Unfortunately, I could not go. The first Life Expert Center outside Belgium, which is in Renji Hospital, Shanghai, under the guidance, lead, and enthusiasm of Giuseppe Bigatti. And for this occasion, we jointly wrote the guidelines, which is a book of 130 pages, and which I think is very practical and very helpful for somebody who wants really to enter into this Life Expert Center methodology. And I'm sure Bigatti, he's doing already a mass amount of patients per day, because his center is obviously, as you know, China big, very big. I thank you very much for your attention. It was a real pleasure to be with you. And I hope very soon we see each other back, either in the Philippines or here in Leuven. We prepare the karaoke here because we are trained by you. Thank you very much.
Thank you, Professor Campo, for that very comprehensive and very informative lecture on office hysteroscopy. So I think that will be one of our wish list for this Christmas, to have all those instruments in our minimally invasive unit. Okay, so we'll move on to the next part of the program, which is the question and answer forum. Okay, so there are some questions posted on the Q&A box. And in the chat box. Okay, so the first question in the chat box, I think this is for Dr. Campo. It came from our past president, Dr. Zoraida Umipig. The question, Professor Campo, who are the patients that are not ideal for outpatient hysteroscopy without anesthesia? Are there a group of patients who are not ideal for outpatient hysteroscopy without anesthesia?
There are easy and difficult patients, but everybody is ideal. So what we do is for outpatient diagnostic everybody, because the questionnaire is without anesthesia.
Yes.
And there I must confess and stress that in Belgium, we need to put some sort of anesthesia when we do surgery. Otherwise, we do not have governmental reimbursement. And so we do not do surgery without any form of anesthesia, except obviously it's a polyp which is suspicious, I remove it. But if I do this too much, I get from the hospital director and the ambulatory center director, I get a a special letter. Please, please, please don't do this. And so I'm not well placed to say without anesthesia, but without anesthesia, for biopsy, for everything, there's no rule that we say you cannot come. The difficult patients obviously are the menopausal ones and patients nullipara with congenital malformation or whatsoever. But I assure you that the vocal anesthesia, the environment of the light environment, and the excellent nurses we have helps enormously. A lot of patients say, oh, I got an hysteroscopy outside and it was so painful, doctor, I need anesthesia. Not one time we needed to give anesthesia. So this is for the diagnostic part. For the operative part, there is no discussion that there are patients which you should not do in a purely ambulatory setting. Big myomas, don't do this. This is risky. We have had a very nice lecture on the, so big myomas, don't do this. You need recovery. You need post-operative care. And my patients go home within 1 hour. If they cannot leave the facility within 1 hour, shout with a smile, then I've made a mistake. And so it's written like a complication in our center. I have 3 complications in 10 years. It's vice versa. So, and always because we want to go further, more myomas. Oh, we have a loss of 3 liters. What do we do now? It's saline, but 3 liters is too much, and so on. So myoma, no. Patients with ASA score above 2, you have to do individually. Placental remnants, which are bleeding with vascularization, you do a Doppler, you say, no way. This will bleed like hell. You cannot do it in an ambulatory setting. So we have a list of very clear indications. And we have tested, because we have the same facility in our hospital. We have it outside and in the hospital, but totally separate from normal one-day care clinics. And until now, the last 5 years, we do not have 1 complication. So I think our indication is important. And with this indication, this morning, I had 9 surgeries. Yeah, you are in the evening, eh? I'm midday. So I had to hurry because it was difficult echelon, but we succeeded. And we put the word. So everything which is under ultrasound, everything which can be done with small instruments is for ambulatory setting. Once you go with big instruments, if you need a 26 French resectoscope, stay in the hospital.
Professor Campo, with regards to that, is there a cutoff size for small myomas that you can do, or even polyps? What is the cutoff size for ambulatory setting?
Polyps, there is no cutoff size. There is only tissue. How strong is the tissue? That's for polyps. It's a myoma-like polyp, then it's different. But if it's a soft polyp, the size doesn't matter. For myoma, when it's more than 2, you have to discuss. Nobody can put a myoma more than 2 centimeters measured in ultrasound in my OR without my personal permission and without I've seen the patient personally. If you have 3 myomas, they're all 2 centimeters. This takes time because the shaver does not work frequently for the myomas. Maybe it's improving. Today I did a 3 centimeter myoma with the shaver, putting the shaver on 1,500. And this was working. When you put it on 5,000, it didn't took the myoma. But 1,500, it worked and we could take the myoma. But there are limitations. So take as a firm limitation 2 centimeters. Everything above, you have to decide. Above 3 centimeters, there is no discussion, normal OR. The location of the myoma, for me, does not matter. Because the technique we use is, as it was very nicely discussed before, we use the cold loop dissection. You don't do it with the cold loop, you do it with the scissors and the trophy, but it's the same technique. It's the Mazon technique, which is really fantastic. And then the myoma is, when you have put the myoma out of the capsula, then the myoma is devascularized. Then you have time to remove it, etc. Very good technique. But the size is important. Like Emmanuel said, 4 centimeters, oh my God, laparoscopy, tack, boom, out.
Rudi, in connection with that question, you actually do pre-treatment. This is probably also can be answered by Dr. Joanna. Do you do pre-treatment for big myomas prior to surgery?
I will leave this to Joanna.
Well, most literature says you have to give your GnRH agonist for at least 3 months. All the readings I've gone through, and that includes papers written by Dr. Rudi Campo. So doing the pre-surgery suppression is very important. It lessens the time for operation and of course complication. Any other thoughts, Dr. Campo?
No, you're a very wise woman.
I read all the articles. I saw your YouTube, all those things, and I am very humbled to be part with you today.
Okay, so there's another question here for Professor Campo. Do you do cervical ripening or cervical priming prior to outpatient hysteroscopy with trophyscope? And what do you use?
Never.
If you do cervical priming, what agent do
Never.
you usually use?
I never prime the cervix. Never, never, never. So when you have a fully closed cervix, which you frequently have in menopausal women, even with a serometra or hematometra, you know already from ultrasound, oh my God, it's fully closed. So you prepare the patient that you will go, that you will do some surgical actions to try to find the way to the cavity. And always with the scissors, with the sharp scissor, with the sharp point, and with the smallest trophy scope. I open on under vision, sometimes with ultrasound guidance, then the nurse does the ultrasound. I open under vision and I bring the cervix such that I can introduce the 2.9 millimeter trophy scope. And it's really extremely seldom that it doesn't work. And it's less, and the ripening was because, as it has been shown by Dr. John, a lot of complications are the perforation due to the blind dilatation. When I was young, the most difficult part sometimes was the dilatation. I put a POTZ out. I'm at 6, I can't go to 9. I have to go to 9 or 10 because it's a resectoscope I have to use. It's a catastrophe. Now then, ripening was maybe okay. But now, if you go with your largest diameter today is 6.3. And you do with that 95% of all surgeries. So you don't need ripening. Only when you go with the big ones.
So that is true, actually, Dr. Rudi, that cervical ripening is not that important.
Yeah.
Because I read through many articles, they said it's not that, because more complications does arise from it. But here in our country, we doing cervical ripening as recommended prior to the operation. Now, until we have the scope that is of small caliber, I think the practice of cervical ripening is not going to be lessened at the moment. Because the scopes are large diameter. Don't have trophy scope, but only St. Luke's has it.
Okay, so thank you for that, Professor Campo. Okay, so we have another question here, and I think this is directed to Dr. Joanne Tan. Okay, so during hysteroscopic myomectomy, is it also advisable to do endometrial ablation, especially among older women in which fertility is not a concern anymore? So doing endometrial ablation or probably resection also of the rest of the endometrial cavity together with the hysteroscopic myomectomy. Is that advisable, or is it recommended?
The way I look at it is, if the patient is trying to do you're doing it because you don't want the patient to get pregnant anymore, or because
I think the question is if, for example, the patient is already like perimenopause and she has a submucous myoma, and hysteroscopic myomectomy was the choice of surgery. Together with that hysteroscopic myomectomy, do you also recommend doing endometrial ablation on the rest of the endometrial lining so that she will not probably bleed anymore?
First of all, this is a postmenopausal patient who had developed a submucous myoma. So that fact it alone, you know that the endometrium will be thin, will be very thin, because supposed to be less than 0.4. And because of something she developed endometrial, I would not go into endometrial ablation. Because first of all, what is the advantage of doing such ablation for this patient?
I think Dr. Joanne Tan, I think the question, the one who posted this, was talking about women still not in the menopause. It's in the
okay, so if it's the perimenopause, there are other ways of doing things to avoid. So mainly, why is the ablation being done? Because she doesn't want to get pregnant? Is that the reason for it? Kasi you're saying that it's perimenopause,
No, she just does.
submucous myoma. I would not go into an endometrial ablation for this case. First, what's the indication of the ablation for? There are many ways to stop. If you don't want to get pregnant, there are other methods to be much less invasive, much less complicated. Now, if you see, the question is quite tricky. If you're talking about perimenopause, it's a different idea as postmenopause, because initially the statement that you asked was postmenopause. So
No,
if it's perimenopause, what is the indication for the endometrial ablation for? Is it for contraception, or is it to prevent endometrial hyperplasia in the future? Is it because you want the patient not to bleed anymore? Okay, so for the indication for an ablation should be very valid. I think should be strongly indicated. For every procedure we were taught, do no harm for patients. So if you are not so well adept, I have cases who did endometrial ablation who underwent. A few years later, they developed endometrial CA, adenocarcinoma. So how do you prevent that? It's just a plain simple endometrial ablation for an indication that is not there, not strong enough. The answer is no. I would just plainly do what I need to do for the patient, submucous myoma to be removed, which is causing some problems, mainly bleeding. AUB due to submucous myoma. So I will do my myomectomy, not together with an endometrial ablation.
Okay, so Dr. Campo, you want to say something?
Again, no, because I agree totally.
Okay,
We
so
never do endometrial ablation.
Okay, Gladys, are there more questions in the chat box? Or?
I'm not sure if the anti-adhesion gel is available here in the Philippines. Are there any other medications we can give to prevent adhesion formation?
No, the only thing which so the first obviously is you have to have careful surgery, and surgical techniques is important to prevent adhesions because the gel will not do the job on its own. But if there is no gel, actually there is nothing. There are only 2 gels on the market. They are the same. We use the Chinese one because they have a longer lifetime. They stay longer in the cavity, and they have no animal products in it. But that's the only thing we have. The balloon of wart is a good alternative if you don't have the gel. The balloon of wart is made by Cook and is actually made for the Bartholinitis, so it's not the indication. So we found it and we tried it out together with Jaime Ferro from Valencia, and it is really because the IUD doesn't work. Whatever you put in the cavity doesn't work. Amnion grafts do not work. And then we found this very simple balloon, which is really impressive. In really cases where you repeated adhesion formation, if we put the balloon, then we saw very good results. But also with the balloon, we put the gel. So it's better to call the Chinese and say, bring me some gel. And I saw a question also on the adenomyosis, if the size, if there is a limit in size. So in the adenomyosis, you have cysts and you have adenomyoma. Big adenomyoma, we do by laparoscopic surgery or microsurgery. But if the cystic adenomyoma, which is mostly related, not always, but mostly related to the endometrium, there the size is not so important because you open it, you clean, and then you decide. either you leave if it's too big, you say, I will damage everything, then you just give the patient generates analogs for 2 months, and you go back, like you do with the myoma. And then you open again, because it will close again. You open again, and you remove everything. But until today, the cysts I have treated, we could do in 1 session. For the adenomyoma, again here, if it's more than 2 centimeters, if it is intramural, or if the alienation with the serosa is not clear, we don't do by hysteroscopy.
Okay, so we have another question in our chat box from Dr. Campo. The IBS, I think this is for for Professor Campo. The IBS is an oval and concave shaver. When do you use each one? The IBS also has a 19 French and a 24 French size. When do you use each size?
Always the 19 French. I do not, because the 19 French and 24 French optic can adapt all the shaver blades. So that's really, really, very good and well done by Storz. So you don't need a different optic for a different blade. Then we have the blades. We work with the closed blade, the poly blade. The open blade is dangerous because you can perforate just by putting your shaver. So if you use the open blade, which is designed for myoma, it's okay, but be careful. So it cannot be used by routine in our department. In a standard set, we don't put the open blade. The open blade is only for expert surgeons.
Okay, thank you, Professor Campo. And in the interest of time, I think we're just allowed to have 1 question. So there's a comment or a question for Dr. Joan Tan in the chat box. The cold loop resection has more advantage than the loop with energy, for it can be used repeatedly and less uterine adhesion. What are the requirements to say that it is okay to use the cold loop resection? And is there any risk of using the cold loop resection?
Well, for those, personally, I have not done the cold loop resection yet, but I am intending, if I get the right instrumentation that is available in the hospital. I think the requirement is expertise of the surgeon, number 1. Number 2, because if you're just on the learning curve, you're just starting it, you need some assistance from somebody who is an expert. Number 1, that's a very requirement. Number 2, you have to know how much of the myometrium is going to be involved. So pre-operatively, and as Dr. Rudi Campo would do, intra-op ultrasound guidance. Okay, that is a very, very important requirement. So you have to have somebody doing it within the operating room, within your OR table, doing it to guide you. Number 3, when you say cold loop resection, you saw the video. Actually, if you go to the YouTube, you can watch it very closely. It's the right angle thing that Mazon has done it. Just go cross street, going through the fibers, and then pressing it on so that you are pushing in eventually the intramural portion towards the cavity. Okay, so it looks so simple. If you do have an opportunity to have the right instrumentation, I think we can go ahead. But may I ask, how many of us in the PSGE board has done the cord loop resection without thermal energy? Okay, so the requirement, another requirement is you have to have the available instrument, the right instrument. That's one of the pointers that I had pointed out this evening when I gave the lecture for the basic principles. So it's, as Dr. Campos said, if it's 2 cm and above, you have to consider something else. If it's 6 cm, it's at 8 cm. Even if it's not the location that matters, it's where is it, how much involvement of the myometrium, and then are you adept in doing something like that? So for learners who are starting, I would not suggest that you start with a smaller one as you go along. with the right instrumentation, prepare the patient adequately, know your ABCs. So you know what to watch out. What are the signs of having fluid over distension? What are the signs that the patient is having venous? And then it would be nice if the IBS shaver comes along. Then I think it will be safely, as we progress in our techniques, then I think there is no complication to be garnered if you are very scrupulous in the preparation for this patient.
Yes. Okay, thank you, Dr. Joanne Tan Garcia. Okay, so I think we have discussed, and thank you again to Professor Rudi Campo and Dr. Joanne Tan Garcia for those very informative lectures for tonight. Now, we'd like to call, at this point, we'd like to call on our Secretary of PSGE, Dr. Ney Abat, okay, so to give some important messages, okay, and information to our members and participants. Okay, so Dr. Marinela Agnes Abat is the current president of the Philippine Society of Reproductive Medicine. She's the secretary of the Philippine Society of Gynecologic Endoscopy, the chairman of the Department of OB and Gynecology, Victor Potenciano Medical Center, and she's also the section head of reproductive endocrinology and infertility at the Medical City. So Dr. Ney, please give the important announcement and information for our members.
Thank you, Dr. Ann. So we would like to remind all our members that in order to maintain good standing, for the year 2020, he or she must pay the annual dues on or before December 15, 2020. In lieu of the annual convention, he or she must attend 3 out of the 7 hosted webinars by PSGE this year. And attendance to the POG's PSGE pre-congress on October 21 is also a must. We would also like to remind everyone that registration to all PSGE webinars is complimentary. So we would like, next slide, please. Okay, so we would like to invite all of the members and fellows to a special meeting and election on October 21, 2020. The election will be held 9 a.m. to 1 p.m. and the special meeting will be at 3 to 4 p.m. So mechanics of the election will follow. We will send you an email and separate links to be provided for the election, special meeting, and the pre-congress webinar. So see you all on October 21. So for our closing remarks, may I call on our very energetic and innovative Vice President, Dr. Maria Antonia E. Habana.
Okay, it has again been an interesting evening. I would like to thank our faculty, Dr. Rudi Campo and Dr. Joanne Tan Garcia, our chairs, Dr. Ann Trinidad and Dr. Gladys Tanangonan, our dear President, Dr. Prudence Aquino, and our BOT Secretary, Dr. Ney Abat. I would like to thank all our participants for attending this webinar. This webinar is supported by an unrestricted educational grant from Karl Storz, Endoscopy Philippines, and is the last of the 3-part series for this year. But we do hope you would continue to be our partners next year. Claire, Lawrence, and Henry, maraming salamat. I would also like to take this opportunity to congratulate Dr. Rudi on his Life Expert Center and hope that we can have a similar one in our country. I would like to extend an invitation again to Dr. Rudi to join us in one of our webinars or in our virtual convention next year and hope we can share the karaoke mic and Belgian chocolate with you in the near future. For our participants, you will receive a survey. Can we have the next slide? After this session, and your feedback helps us choose topics that are relevant to your practice and your input is greatly appreciated. A post-test will be sent for CPD requirements. This session has been recorded and will be available in the website of PSGE in the near future. Can I have the next slide? Our last webinar for the year will be tomorrow, that's September 24, again at 8 to 10 p.m. on patient blood management. a topic close to the heart of our past presidents, Dr. Delphine Tan and Dr. Saida Gamilla. Our faculty will be Professor Arya Shander from the USA, Professor Eileen Manalo, Dr. Asuncion Fernandez. Prudence and I will share this session. And then next slide, our pre-congress entitled Surgical Pearls in Gynecologic Endoscopy will be on October 21. That would be at 4 to 6 p.m. We encourage everyone to register early. As of Monday, we had already more than 800 registrants. So we hope to see you then, no? And may I have the next slide? Our simultaneous session during the POGS Congress will be on November 11. That's 1:30 to 3:30 p.m. And I can assure you that we have prepared an exciting program for everyone. Again, this concludes our webinar, and I hope to see everyone again tomorrow. That's September 24 at 8 p.m. And please try to log in early as it is a new platform. So thank you again. Stay safe and healthy. So Pasko na. Ano man ang uno sa ating buhay, ang sinag ng tala ay nagdadala ng pag-asa. Okay. Yay. Can we ask Dr. Rudi Campo to turn on his video so we can have a gallery shot with him? Dr. Rudi? Oh, there you are.
Sorry.
Thank you so much, Dr. Rudi. It was a good smile, a great smile. There you go. Yeah.
Thank you very much.
Thank you.
Thank
you,
you.
Dr.
Thank
Rudi.
you.
I'm so sad I'm not with you.
Yeah. Same here.
We
We'll
miss you, Dr. Rudi.